now I will present the Professor Imad Zakharey from USA. We'll talk about open conversion after EVAR.
Good afternoon. Thanks for the privilege of presenting no disclosures, conversion to open surgical repair after failed EVAR. This is increasing since there is more EVARs being done and more patients are being followed. There is immediate conversion during the index procedure. There is lead conversion, which can be an emergent like rupture, a semi-urgent like explantation of an infected graft, or an elective after failure of endograft like for endoleak and failed secondary procedures. Immediate conversion, the incidence is 0.7 to 1.7%. It is decreasing immediate conversion because of improvement of devices and experience of interventionists. Example are rupture of iliac artery, technical problems with contralateral gait, deployment, avoid by choosing the right graft, technical experience, late conversion, and this is what the main subject of today. There are secondary interventions that we do. It is on failure of these secondary interventions, or if they are deemed to be unsuccessful, that we do open repair. Late conversion, you need to get the equipment, the exposure, control, proximal and distal, and closure of the sac. The equipment, you need to review the graft you're going to. I'm holding a graft that we're taking out next week. You need to test the graft, test the stent, even sew to it, and get the cutting wire and see if the stent can be cut. And it's easy as for open repair, AAA repair, cell saver, Teflon pledget, heavy scissors, external cutting wires to be available. Distal control is that you can clamp the distal graft so long there is no balloon expandable stent. And you open the sac. The key is after you put your clamps and heparinize, you open the sac without disturbing the graft. So you see where the leak is coming from and determine, at this point, you have to think for a few minutes and decide what are you going to do. The decision is either open secondary intervention, explantation, or a hybrid procedure. And the decision is based on the patient physiological status and the type of the graft. There are different types of grafts that can be more or less complicated. The decision, one of the options is open secondary intervention, either suturing the site of the leak and closing the sac tightly. However, if this fails, then you have burned the bridges for and violated the planes for an open surgical repair for the future as well. Explantation, collapsing the suprarenal stent if there is, that can be with an empty 20 cc syringe. You advance it. Some people advocate putting a cold saline of over nitinol to collapse it. You can crush it. Most people use external cutting wires to cut as much of the stent and leave the parts that has the barbs inside. And then operative technique, there's a hybrid. You can leave the proximal part of the stent and the distal limbs and repair the segment in the middle, which is the most commonly procedure done. You can keep something called, you can create a neo neck, which you clamp supraceliac here, you sew to the stents in place and the proximal cuff of the graft here, that's proximal, and you put your open repair. So this is called hybrid procedure. It's less invasive than total explantation. This is different studies on explantation. In conclusion, immediate conversion, avoid by good planning. Mortality is still high with immediate conversion because you wasted time, you had maybe hemodynamic instability leading to immediate conversion. Late conversion, if it's for an emergency, it still has a very high mortality, but late elective conversion for failed endovascular intervention has a reasonable mortality, although challenging technically, it has a reasonable mortality comparable to an open elective AAA repair. Therefore, do not delay open conversion of an enlarging sac, especially for a large AAA, in favor of multiple secondary endovascular interventions, because you carry the risk of rupture while you're waiting, and you complicate the open conversion, and you are operating on an older patient and more sick patients, maybe 5-6 years down the road. Keep your open surgical skills, which is an issue because many of our open procedures now are only conversion after EVAR or rupture aneurysm when our trainees are not getting enough open surgical repairs. Thank you and have a good